Good afternoon. It's a great pleasure, and I would like to thank the scientific committee for inviting me to contribute to this symposium dealing with pH-positive leukemia. And in the second part of my talk, I will deal with the role of stem cell transplantation in Cr1. And I will try to discuss the following topics: how to identify high-risk patients, chemotherapy versus stem cell transplantation, lessons from clinical trial, what is the best regimen to be used for pH-positive ALL in case you need transplantation, what is the guideline for the use of TKI after stem cell transplantation, and finally to discuss why CAR-T can potentially replace tomorrow stem cell transplantation in this setting. First of all, let me share just as an introduction that defining the very high-risk patient, in general in leukemia, but more specifically in the setting of a genetic-driven leukemia, as it is pH-positive, is first of all is a changing time, it's a dynamic process, because of course before the introduction of TKI, most of the patients with pH-positive ALL were eligible to transplantation in first CR. And accordingly, and then after the introduction of TKI, as we discussed previously, there was, of course, a completely change in the landscape and progressively reduction in all the experience of the European and North American study groups of the need of considering stem cell transplantation in first CR. Usually, risk group rating with less than 30 to 40% with chemo only are identified as very high risk. And accordingly, it's clear that even within pH-positive ALL, relatively homogeneous genetic subgroup of ALL, there is still a fraction of the old patients that do need to receive stem cell transplantation in first CR. But of course, as we'll see in my discussion, the criteria to define those patients are still not fully clear. What are the non-prognostic factors in pH-positive ALL? There are non-prognostic factors: age, white blood cell count, early response to treatment, no response, molecular response, and morphological and molecular response as defined by remission at day 28. And this is just a prognostic factor which came out from one of the largest cooperative study within the IPFM, which is the ESFL 2010, and recently published in Lancet Hematology. And you see that one of the intriguing and we still standing prognostic factor is the white blood cell count diagnosis. And if you look to the outcome by white blood cell count in terms of number of white blood cell count, you see that there is a significant difference in the Philadelphia positive ALL. And by contrast, as we'll discuss later on, we didn't see a significant difference and benefit of the transplantation overall. This has been even confirmed by the previous study, and we basically reported recently the long-term follow-up. So basically, even in the 2004 ESFL study, apparently the white blood cell count, even in the context of a study where significant proportion of patients did receive transplantation, stand for its prognostic impact. What are the novel prognostic factors? The novel prognostic factors rely mostly in the genetic response, the use of minimal residual disease, the additional genetic lesions, such as the deletion and mutation of the gene encoding the ICROX1, and of course, the BCR-Abelson fusion variants. With respect to the MRD role in pH-positive ALL, there is no doubt that the MRD of the IG and TCR is a strong and independent prognostic factor in all subgroups of childhood ALL, including pH-positive ALL. By contrast, with the introduction of the TKI, especially for what I had shown before, that the early introduction at day 15 from diagnosis of the TKI, the clearance of leukemia is definitely faster as compared to chemotherapy only. The results of the prognostic factor, in other words, whether the MRD at the end of the induction still stand for its prognostic factor, are still not so strong as it was in the pre-TKI era. And the other question, of course, is what is the best molecular marker to be used, either the clonotypic marker, the IgTCR, or the fusion transcript. These are basically the results of the 2004 study in which TKI was given, I remember, only at the end of the induction. So basically for the first 33 days, the patient did receive the pre-phase and chemotherapy only. And then in the study, the TKI was introduced after the end of the induction. And in that context, the impact and the prognostic impact of MRD was very strong by defining a subgroup of patients with a complete clearance of the blast at day 28 to achieve an outstanding outcome, as you can see. So basically, this is stratification of the end of the induction MRD, which is very similar to all the different subtype of BCP-ALL, which has been reported by our group in the context of the IBFM and IOP studies since 2000. Novel prognostic factor, one very interesting factor is, of course, the deletion of and the mutation of the ICROS encoding gene. ICROS is an important transcription factor which code for the very important in B cell ontogeny and defining the fate of the B cell from during the differentiation. And our group and jointly with within the IBFM consortium reported that an unfavorable outcome for childhood BCR positive BCP-ALL with ICROS deletion irrespective of imatinib exposure. And the other important things is a good risk patient with ICROS wild type responded remarkably well to imatinib containing regimen, providing a rationale to potentially avoid hematopoietic stem cell transplantation in this subset of patients. Because a key message that I want to share, that different from an adult patient in the pediatric setting, all the effort that has been done so far by the two largest consortium, the ESPOL in the Europe and the IBFM context and the COG, was progressively to define and to reduce the need of performing bone marrow transplantation in first CR. And of course, all the effort to define novel prognostic factor is moving in that direction to identify as early as possible those patients, very few, that are potentially eligible for transplantation. Even because if you consider these are basically the results, there are very few studies where basically the patient were compared in the same trial by having stem cell transplantation versus chemotherapy. And of course, if you look to the DFS, of course, the stem cell transplantation in the good risk patient as defined according to early response molecular response, the stem cell transplantation do better. By contrast, if you look overall to the survival, you don't see the benefits, suggesting that in that sense, it's probably reasonable to take the risk of transplanting patients in second CR if they behave as good risk, instead of transplanting, as we did in the past, more than 80% of all patients, including good risk. But it is not the same in the poor risk, and of course the fact that apparently the survival is better, at least in this study, probably rely on the fact that you have and higher mortality in the stem cell transplantation as compared, of course, to chemotherapy alone. So overall, the message is that we do have a limited fraction of patients with Ph-positive LL in pediatrics that should need to perform stem cell transplantation in first CR. Even in the poor risk, unfortunately, the answer is probably not the bone marrow transplantation, although at the present time is the only chance that we do have, although in a limited fraction of patients. And as you can see, if you move progressively from the 2004 ESPO as compared to the COG, where 81% of the patients did receive bone marrow transplantation, now according to the 2010, only less than 40, and actually in the ongoing study, which is still an open study, less than 14% are basically eligible for transplantation in first CR. So the message is reducing bone marrow transplantation, take the risk in the good risk Ph-positive LL, which account for more than 85%, according to early response, due to the fact that we introduced early on imatinib to transplant those patients in second CR. What is the best regimen? And I'm very pleased on behalf of the forum to present the extraordinary work that Christina Peters from Santana Kinder Clinic in Indiana, for all the study groups reported recently in JCO, the fantastic study of the forum, a study which basically compared chemotherapy-based regimen versus TBI, and in a randomized manner, closing, unfortunately, because basically all pediatricians would definitely be better, would have been more happy to have the opposite results of this study. But actually TBI is still the only regimen, and only in every type of plot subgroup analysis, TBI stand better. In the forum study, there were only limited number of Ph-positive, but even in those without a significant, without the possibility to perform for the limited number, the power of statistical forest plot analysis, definitely there is no doubt that the TBI is the regimen to be moved. What is the current policy of the use of TKI post-TKI? Of course, we do have experience in the adult setting. Probably one of the largest studies reported by Brissot on hematological in the adult setting, clearly demonstrate a favorable impact of on DFS on multivariate analysis, but more recently, the CI-BMTR analysis of TKI maintenance after HSCT did improve, at least for the adult CML, did improve a survival benefit. This is one of the reasons why in the ongoing ESPO COG trial is exactly studying the feasibility of post-transplant TKI in high-risk Ph-positive LL in order to answer and possibly to provide evidence in terms of clinical care or whether there is a rationale to be used. Finally, let me touch upon one point, which is one of the most extraordinary advances in the immunotherapy field, which is, of course, the use of CAR-T. CAR-T is of course, well known to everybody, but I want just to mention that this very famous pediatric patient, Emily Whitehead, is probably one of the most famous pediatric patients in the world. Emily was a very unfortunately experienced relapse refractory after the second transplant, acute lymphoblastic leukemia with no chance to be treated, and a UPenn with the work of Shannon Mad, Steve Group, and all the groups of UPenn was successfully to demonstrate that by using engineering autologous T cells, engineering with the CAR-T, the patient did achieve a fantastic, with a single infusion, a fantastic remission, which is still stands after many years after the successful treatment. And these are basically the results of the extended use of Tisangel Leucleocell. Our center in Monza was the only center in Italy which has been actively part of the registration study of this study. I'm very pleased to mention Professor Adriana Balduzzi, who is managing with fantastic skill all this program in our center. And again, the question is, there is no doubt that there is a powerful tool to achieve remission. The question is whether how many patients receiving CAR-T can spare the use of possibly a second transplant, because most of the relapsing patients, most of the patients eligible to CAR-T are relapsing resistant patients. And I want to share this concept to you with respect to the question, can CAR-T replace SCT? At best of our knowledge, probably only 25%, one out of 4 of the patient that can receive Tisangel Leucleocell can probably spare, according to the B-cell aplasia recurrence or the disappearance of the CAR-T in the body, and according to the risk of recurrence of disease. And so in that sense, the question is, considering the profile of toxicity, in order to, we want to think about something that can substitute, even in the allo setting, the use of SCT, is definitely you need the possibility of repeated infusion and accordingly less toxicity. And that's the reason why our group in Monza has launched a study in 2015 to develop an academic platform which is rely on the use of non-viral method, the Sleeping Beauty, which has been proved to be successful and recently reported in JCI for the treatment of relapsing refractory leukemia after stem cell transplantation in a pediatric patient, but mostly in adult patient for whom the use of the approved Kymriah product is not available above the age of 25. And finally, let me touch upon the last point of my presentation and how to treat relapse Ph positive LL. I apologize for the mistake of the relapse. First sentence, which I believe is very important as a sort of conclusion of my contribution, the first part and the second part. Many patients with relapsed Ph positive LL has been successfully salvaged through the reintroduction and consolidation followed by SCT, especially those who did not receive SCT in CR. And if you compare the overall survival on the ALL-0062 of the COG trial, was 86% compared to EFS of 60, clearly indicates that there is still room for salvage, especially if the patient did not receive SCT in first CR. Of course, there are many experiences in the adult setting by using prednisone and blina plus TKI in order, of course, that's been demonstrated in the elderly patient, but by which you can probably achieve with a chemo-free approach a second remission and accordingly the possibility, according to the Karnofsky, of the second transplant. CAR-T or a second SCT can be considered based on the remission status. The BCR-Abelson amplification, and to less extent, because it's a very rare event, mutation occurring in the fusion gene, by providing higher dose of imatinib or dasatinib can be explored as well. And finally, as already mentioned, children with Ph positive LL did not develop point mutation, even relapse. So the conclusion of the second part is basically TKI and chemo have dramatically reduced the need of SCT in CR1 and Ph positive LL in pediatrics. SCT should be limited to high risk, and of course the question is, who are the high risk patients? And I've tried to discuss all the known prognostic factors to be considered. TBA-based regimen is the only option based on the affirmed results. still open the need of TKI after SCT. And finally, I strongly believe that monoclonal and CAR-T might further limit the need of SCT in the future by improving the cure rate and reducing the long-term side effect. And finally, let me thank all the people. I didn't have these slides in my previous presentation, especially Professor Balduzzi and Professor Rizzoli, who are dealing the team of the EMONC and the bone marrow transplantation in our center, and of course our center and all the team, and most important, our parents association. We strongly support our daily work in our center, Maria Letizia Verga in Monza. Thank you very much for your attention.